Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There, episode 22. We have a dual purpose in this episode, a really good discussion on child and teenage mental health and the role of social media in the growing problems of Gen Z and the youngest children, Gen Alpha. And we're talking about this with a psychiatrist from the United Kingdom's storied national health system as part of revisiting the NHS and its ongoing shortages and waiting lists from the standpoint of the doctors who keep it going, often with great difficulty. If you haven't heard or watched episode 11, perhaps you might want to. That's the one where we did the overall look at the NHS and its current woes. The NHS began in 1948, and that is 75 years ago. And along with the slightly younger Swedish system, it's the basic model for taxpayer-financed, government-controlled universal health care, free at the point of use. Many of the NHS doctors the patients see are also its caretakers, helping their local services function while they also work in their specialties, like my guest today, who lives and works in Wales, one of the UK's 4 devolved nations. Dr. Amani Hassan is an experienced practicing child and adolescent psychiatrist in Wales, a consultant, as many doctors are called in the NHS. She chairs the Faculty of Child and Adolescent Psychiatry at the Royal College of Psychiatrists in Wales and works also in learning disability psychiatry. There's a more detailed bio in the show notes. I asked Dr. Hassan to start with a quick overview of the NHS, and we got to meet each other in an earlier Zoom, so we're on first-name basis. Amani, thank you so much for coming on the podcast, and welcome.
Thank you for inviting me.
You're in Wales, right?
Yes.
So the United Kingdom, in terms of healthcare, has something called the NHS, which is essentially the granddaddy of all universal healthcare systems. And it works a lot differently than anything we really have in the United States. So could you just, just give us a sense of how it works?
So the NHS is a publicly funded national healthcare system, all right, that provide universal health cover for every legal resident in the UK. And it's free at the service of use. So anybody who needs the NHS, that service will be delivered free, regardless of that service, be it going to accident and emergency, going to see his doctor, going for a hospital. So this is a free service, all right? And funding that services come primarily from taxation. So although there are other pots, but it's mainly taxation. And although it's a publicly funded national health care, that doesn't mean we don't have private providers. But private providers, it comes with your own choice. So nobody's forced to have a private provider at all. And it's up to people who don't want to wait or got enough money, they can go privately. And if you go privately, that doesn't take you off the NHS system, as in some countries in Europe. If you register privately, you're not allowed to public things. For example, in Germany, there is a system like that. Saying that, I'm going to explain it more. Because we are 4 countries, the 4 countries are part of the UK, yes, but they are devolved government. So Wales, for example, when I say it's devolved, the central government in London will give money to these countries, and they are kind of free to use their percentage of the money allocated to them, what percentages will be allocated to health, for example. And although the practice is more or less the same, but I will give you an example of a slight variation. For example, the prescriptions in England are not free. So there is a cost for that prescription in England. So if the doctor prescribes you any medication, you have to pay. and that figure is fixed. But in Wales, for example, the Welsh government chose to make all prescription free. All right.
Interesting.
And also, just to be fair on people who are unable to pay in London or in England, sorry, if you don't have money or you are on benefits, you do not have to pay that money even for that prescription. Overall, we abide by kind of national guidelines. For example, the NICE guidelines. So with the NICE guidelines, you make sure that even whatever way you choose to spend your money, you're abiding by a national guidelines.
I'm going to stop you for a second. I'm going to ask you just very briefly to explain the NICE guidelines, because it's something in America we've never heard of.
Okay. So NICE guidelines is short for the National Institute for Clinical Excellence. So I'm going to talk to you more about guidelines. So NICE, what does NICE guidelines do? They provide recommendation for healthcare professionals on the appropriate treatment and care for people with a specific disease and condition. The guidelines cover areas such as diagnosis. So when I diagnose someone, I need to make sure that I abide by NICE guidelines. It covers treatment, prevention, management of various health conditions. And the NICE will come with these guidelines after doing, so kind of consulting expert in each field and look at systematic reviews, really, which is a high level of research. All right. And if there is no systematic reviews, they will look at randomized controlled trials. If there is no randomized controlled trials, they will look at expert opinion. And they update. NICE is not mandatory, but it's a kind of authoritative kind of organization. So a patient can file a complaint against a doctor and say, I wasn't happy with that treatment in any part of the UK. That doctor, if he or she uses NICE guidelines, that will be a defense in court.
Sounds to me like an effort, at least, to be sure that if you live in a poorer area of the country, you're going to get the same treatment that somebody who lives in a better area of the country might, so that people are treated the same way, in a sense.
They are treated the same way, and also they are protected in a way, because part of the guidelines also care about cost. So there is cost effectiveness. So because you have to spend according to your budget to make sure that everyone is treated the same, as you said.
Okay, let's go back now to just a little bit more on the structure. The thing that always kind of stops me, that I don't understand completely, is that, okay, each devolved country has its own essentially pot of gold to spend on healthcare. And then within that, it allocates certain amounts to what we might even call counties, but to specific areas. And you can only spend in that budget for that specific area. I'm being very general because I don't really understand it. That's your job.
All right. Okay, maybe I will go back to, again, to the central government, although I'm not a politician at all. Like in 2021, 2022, 2023, the United Kingdom spent 7.8% of its GDP on health. All right. So in a way, this is kind of, will set the scene for you. This is the budget. This budget, you've got priorities. All right. So the priorities for each area is different. But for example, children and adolescents are more important. I'm just giving a rough example. I'm talking about if we look at mental health, and on the same time you look at how do you spend. So do you want to spend your money on prevention more as opposed to treatment, because we are a developed nation? So ideally speaking, according to the kind of policies of developed countries, you have to spend most of your health budget on prevention, to prevent diseases like diabetes, cardiac disease, high blood pressure. You want to make sure that the children are immunized up to date. You want to you want to cater for the aging population. So I'm not a politician in a way on how they allocate all these, but as I said, at the end of the day, you got a budget that you have to spend according to that. And then also you have to look at the prevalence of diseases and what is important. What are and also, and I'm going back to each country. So for example, in Wales, I will give you an example of the learning disability, because I'm a child learning disability psychiatrist. There is no inpatient bed. So if a child with moderate to severe learning disability needed an inpatient bed, there is no inpatient bed because it's costly and it's not used as needed. So, sorry, it's not like there is no demand on it. But if there is a need,
it's not dedicated to that.
Yeah. So if a bed is needed, we can purchase that service from England or Scotland, wherever that bed is available. So there is an interaction and there is cooperation between the four countries.
Let me ask you just a general question. You explained all of this as it should work.
Yeah.
Does it work?
All right. This is
it working might be a better, situational question right now.
Okay. If we look at it as it's a free service, I would say it's doing great. All right.
At least waiting lists.
Yes. But there is waiting lists. There is shortages of professional. And this is, I believe, even in the US, there is a shortage of staff, despite the US is spending almost 20% of its GDP on health. So we've got waiting lists, but waiting lists also, how can I say, they differ according to the seriousness of the population. If we're dealing with a child as opposed to dealing with an adult, if you're dealing with mental illness as opposed to dealing with something that could wait, So in a way, it is not working well like it should work, but I believe it's given it's a free service, it's doing its best and it could do better.
Are there really, I'm sitting here on the outside. I read newspaper stories. I listen to podcasts. I watch BBC. And I hear there are 2-year waiting lists to have a hip replacement, that people can't get diagnosed for cancer. They have to wait a year, and this is all kind of outside the biggest cities. This is in the more rural areas. I hear there are people in the hospitals that they have nicknamed bed blockers, which is incredible, because there's no social service to take care of somebody who's not quite ready to go home, but is no longer sick. Is all that true? Or let's put it this way, is it region to region, whereas it might be okay in one region and not okay in another?
Yes, we've got something like a postcode lottery here in the UK. We're not denying that. But as I said, there are challenges that the NHS is facing. So because of these challenges, you're finding all this. As I said, there is shortages of staff, all right. And as I know from just the field of psychiatry, according to the Royal College of Psychiatrists, we're deficient by 10%. So we the capacity of the mental health is, say, with regard to psychiatrists, is down by 10%. So there is a shortage of staff, and funding is an issue as well. Funding is an issue. Saying that also there is other problems, like shortage of staff will lead to more waiting lists. More waiting lists might lead to the NHS appointing doctors, as we call them, locum. Locum is a doctor who you do not pay them just the normal salary, you pay them extra to do a job, and that will lead to like some of your funding is being spent in a ways that you didn't want to do. You don't want it to do like that. So in a way, the problems is we are going through a triangle of funding, shortage of staff, leading to more waiting lists. And it's almost like a vicious circle. But as I said, it's still there are, the government is doing its best to try to tackle this. Added to that, we've got a problem of aging population, so in a way, so it's almost like every year you have to set the balance right, and attend to certain needs.
I have a sense that every country is going through some of the same things. That the demographic Powerball, you might say, that is the baby boom generation retiring, which has been large in every country, is a problem because demographically they have different needs. That children in many countries have never gotten the kind of attention they should get. And now there's a demand that they should get this attention, perhaps because of social media and what it's doing. And then simply the explosion in better treatments and better drugs, and the price, the explosion in the price that went with it. So, I mean, they're big problems that every country has to solve. Is that fair?
Definitely. This is exactly not the NHS alone. So when you're finding that the NHS is underfunded, you probably, I would say, education will be underfunded. Maybe also social services is underfunded. So when the government's struggling with a budget, every kind of service will have its own, fare of cuts, and it will be underfunded. But because the NHS is a very precious thing, and we are very proud of the NHS. So the NHS for the British people is almost, I will say, as important as the monarchy,
Yeah.
So it's always, kind of a hot topic, and it's kind of should be on the top of the agenda of any political party. So because the NHS, we're very proud of the NHS, and I believe, although we've got some private, kind of pots in the NHS, that's stuff that the NHS doesn't fund, but I believe the British will fight to the last day of their lives to protect the NHS. If I'm, if this is the fair sentence to say.
Okay, so with that as a background, let me move on and talk about what you do, because I think this is such a major issue now, both in the UK, but as I said, everywhere. You work with children and adolescents on mental health and psychiatry, and I think most of us just have no idea that kids might be different than the rest of us if you're going to approach, someone who's disturbed about something. Explain to me how it differs, how you treat a child versus an adult.
Okay. I'm going to talk about the NHS again, how the NHS designs a service for children here in this country. All right. Children are a priority to start with, children and adolescent. And by law, the definition of a child is anybody under 18. Okay.
Mm-hmm.
So the way the child and adolescent service is designed, mental health service, or what we call CAMS in the UK, the way it's designed, it's a tier system. All right. So we've got tier 1, which is a universal services. Tier 1, you can find the general practitioner in it, schools, youth service, primary care provider, and it's for kind of symptoms more than a disease,
Mm-hmm.
like symptoms, things that could be tackled easily. You don't need a specialist service for it. All right. Then we got the tier 2, which is a specialized child and adolescent mental health service with the consultant working on it, like I work in a tier 2 and tier 3 as well.
Okay, I got to interrupt you for a minute, because what we didn't do is define consultant.
All right, okay. A consultant in the UK, what did it mean? It meant that somebody who went into basic training, finished the basic training, and then went to a specialized training in psychiatry. And in that specialized training, you do sub-specialize again. And a consultant is somebody who completed all the training required. So you're almost like I would say, an expert in that field. So it's kind of a higher level of doctor in the NHS.
If you are a consultant, couldn't you have your own, private in the sense that
Yes, you can have, but it's according to what part of your job. So you can divide your job. You can say I'm 80% NHS and 20% people, this is according to the contract you sign, but you have to declare that. So if you're doing private work, if you're going to do private hospital, if you're going to do anything, you have to declare that. So there will be no conflict of interest.
Okay. All right. So now that I've stopped your train of thought, let's go back to the actual work that you do, and that children are different in that sense.
Yes. So as I said, the child and adolescent mental health service that comes is divided into 4-tier system. As I explained, tier 1 is universal, tier 2 is specialized, where I work in tier 2, and I work in tier 3 as well. So specialized comes professional. They work in the clinic, mainly is community clinics, and you kind of have, it's an MDT, like you've got other professionals with you, like in the team I work with, I've got a psychologist, I've got a nurse therapist, and I've got family therapist. So the team consists of various professionals. All we kind of treat whatever we think, okay, this child, the family needs family therapy, the child needs medication, the child needs both. So we decide on that. We meet weekly, and we've got a caseload. Then we've got tier 3. These are a very specialized service. Like I work in a tier 3, sorry, like I work for a special group of moderate to severe children with learning disability or profound. I'm talking about like any child with an cognitive or a low or an IQ below 50 who got comorbid psychiatric diagnosis. I see this group as well. So this is a very specialized kind of service. The eating disorder is a tier 3, for example. Eating disorder is a tier 3 service. You've got the drug and alcohol team is a tier 3 services. So you've got the forensic is a tier 3 service. So you've got a special group who needs above and beyond just the kind of the depression and anxiety and the other. There is the early onset psychosis team is a tier 3. Then you've got tier 4, and this is highly specialized services. I'm talking about inpatient care or intensive outreach services, that people who will do treatment in homes, teams that will treat the child at home. All right, so a whole team will go to the child house and treat that child. So this is the level, and every child needs to go. So a GB, for example, a general practitioner for tier 1 cannot refer to tier 3 or tier 4 because these are a specialized service. But a tier 2 consultant in his catchment area can refer to this specialized service if the child needs more. So this is, in a way, if a child presented, let us say, through the GB school or any. So this is the route. The child might come from a different route, might come from accident emergencies. A child who's never known to the general practitioner with any disease or any illness can present with suicidal thoughts, go to accident emergency or emergency service through dialing 99 or crisis team or going through the child line or, through the school. That child can gain entrance as well because of the level of risk. So the whole of the field of psychiatry, by the way, regardless of whether it's child psychiatry, adult, old age, forensic, it's all it all depends on risk and how you assess that risk, then you allocate the child.
Do you think that the services are adequate? For example, in the United States, we apparently have an epidemic of adolescent suicides, child
Okay.
and adolescent suicides, because some of them are very young.
Mhm.
Um, their their parents do not seem to know there's something wrong. Their parents don't take them, to any doctor, to a psychiatrist or anything under that. Um, and although they probably manifest something at school, the schools who all have school nurses, and some of them actually have doctors, don't seem to interact in any way with the parents, um, with the community, with the health system. I don't know. It's all kind of pigeonholed in the United States. Do you have an adequate kind of crossover system where, for instance, a teacher, is going to notice there's something wrong with a child and going to recommend that that child get some kind of evaluation medically or mentally? Um, and can they do that? And then what would happen? I mean, this to me is how it should work. Does it work that way?
It's actually okay. The beauty, in a way, I like to see. I'm someone who like to see positives before I look at negatives. So in a way, how I said children are important, there is no question about that. But the beauty about the child and adolescent service or any service that there is a network around that child. So a child is not an isolated adult. So
Mm.
the child is either in school, and if that child doesn't attend the school in a way, we've got a system in place, kind of to chase the parents, unless they choose for homeschooling. The child, apart from the schools, there are leisure centers, there's the GB, the friends. So the child got more or less a form of a network. The school, they do that. And recently, one of the projects being done in Wales here, we got school outreach. So we've got a group of professionals who will work with the school, but mainly to empower the teacher to the same reason you just said. Okay, how can you detect this? When can you refer? And they will go there almost to do a clinic without seeing the children, but listening to the teacher, listening to their
Yeah,
consent.
that's great.
No,
That's
no, we've got an outreach or outreach
Yeah.
or inreach in school where children could be picked up easily, because you're right. Sometimes the family are not aware of the problem. The child is isolated, or the school is not equipped enough. So the whole idea behind that team is to empower the teacher, train them to be able to pick these symptoms and signs, and even when members of this team will go to the school regularly, they will be able to listen to the teacher and just assure her, okay, your concerns are right. Okay, I listen to what you're saying, but can we do this? Can we do that? Because you will be amazed about most of the problems really could be sorted at school, because many kids I do see, or many kids who do self-harm, they report bullying. So bullying is another kind of pandemic that is ongoing. And we thought if we do work at school, this will ease the problem. So, like, for example, recently we dealt with a school where we felt that the bullying reports that we receive is higher than any other school. So this is what we've got here, that this in reach, or school in reach, it's helping a lot, for the kids who do not have voice, or their parents are busy or careless, or they live with a single parent who's very busy, whatever, because not every child really is got like these caring parents.
And even the ones who care sometimes just don't have
Yes,
time to sit down and look at them and talk to
yes,
them.
yes, yes,
Yeah.
yes. Sorry, I didn't mean caring parents, but the generation we're dealing with is completely different generation,
Yeah.
and sometimes this will cause there will be a big distance between the child and the parent.
Um, there's a great deal of thinking in this country. In fact, we are about to have possible laws floated in Congress to restrict when a child can go on social media, when they can get, there are a lot of people that don't think this is the role of the national government, but it's
Mm.
gotten to be so bad now with our young people. And you talk about bullying. So there are many people in this country who think that the at the at the cause of everything is social media and the ability of or the non-ability of most young people to just put it down and ignore what's being said that they don't like. And that a lot of this kind of blew up after COVID because children were so isolated. Teenagers, especially who really need to be in groups and be together, couldn't be. And so they substituted the social media and the Zoom calls and everything like we all did. But it just doesn't work for kids. Do you have that sense also?
All right. It's a very hot topic, to be honest with you, using a smartphone, internet, social media, for the very reason you mentioned, cyberbullying, more isolation, families don't know much about their child, and the child, almost people start to talk about addiction to the, although there is no evidence, addiction to to smartphones. And there is a terminology now being coined called problematic smartphone usage, PSU. This is people talking about that nowadays. So before I jump into that, I'm just going to go back again to the role of NICE guidelines.
Okay.
So people, there is research, there are papers being published about that, but till now the research is not, how can I say, most of the research is focused on screen time.
Mm-hmm.
As opposed to the context and content. All right. So before we attack the usage of smartphone, let us talk about the positive, because I love talking about the positive first. Okay.
Yep.
So with internet, smartphone, you can read books. Yeah. You can sit down and read a whole book, ebook. You have access to educational resources. And following the COVID, we got now some form of online school. Okay, so you can have your education through the internet. You're connecting to a network of friends from all over the world, as opposed to a small group maybe who bully you and you're not happy with. Some people get pleasure, and there is the gaming itself, the games and connecting with other people. This is an activity, and that produce some pleasure. I do some clinics for the 17 and 18, and they get that virtual clinic from their smartphones. So there is virtual medical appointment with these young people. All right. Also, it helps the child to develop some digital literacy, skills. They develop their skills. They're faster and they're quicker and they know exactly what to do. It saves some time. All right. And also it can expose the children and adolescents to diverse perspectives, okay, about culture, ideas. And also it's important for creativity and self-expression. If we look at the negatives then, because these are the positives which we should not ignore, because to ban smartphone, to say no to social media, I believe we cannot swim against the current, given that we are dealing with the Z generation and the alpha generation. These generation will be born into this internet. Yeah. So we have to speak the same language, with them. So the negatives, you're right. So as I said, it can save time, but time could be wasted, and the child is isolated from his parents. And to the very reason you said, parents, they didn't know what's happening to their child because the child is just on the phone. All right. The context, as you said, could be very distressing, including exposure to violence, being sexually exploited. There is a lot of that could happen without our knowledge as parents. Okay, there is this online bullying, as you said, or the cyberbullying. The other problem as well, money could be spent. I know of children who could take their parents' credit card and just go on and spending.
Oh, yeah. Yes,
endless amount of money. All right. And there is also now some evidence to say that it can make you anxious, can lead to self-harm. All right. And there is this also notion of technology addiction. So you could see there are positive and there are negatives. All right. But up to date, the research that is being done, everyone is using different tools to come to a conclusion. I believe we need to agree. Research needs to be done in the area. We need to agree to what we're going to assess, how to assess it, where is the consensus about it. But I'm not denying there will be vulnerable children and adolescents who will fall victim into that till I design these assessment tools. And these are like any other children who will fall victim to a bad coping mechanism like drinking, taking drugs, doing all this. So we have to do what to ensure parental control till we rectify this, and with regard to screen time and contents, all right, and encourage useful usage. Also ensure that the school is aware, because nowadays the school will say we don't have bullying while cyberbullying is everywhere. All right, so teachers and school needs to change their policies, and also the law need to be kind of those who kind of be responsible for the cyberbullying, so you don't run away with that. And also, I believe we have to invest in the children to have greater self-control and give them digital literacy. So we have to educate the children. It has to be part of their curriculum about
That's it. Where you start, at grade 4 or 5 or whatever grade it is, it has to be. That's the missing key. And I've never heard anybody say that. And you are absolutely on the money, I think, anyhow.
So as I said, and let us not, for me now, I'm not going to say I'm old, but
You're not.
With the kids that I see who are a mixture of the Z generation and the Alpha generation, the first thing I say after I greet them, I say, excuse my ignorance. You can see from my face I'm old. Can you tell me about what is the latest? What does that mean? And sometimes I will know about something, but I will pretend I've never heard of it for them to educate me more and go into their world. Because we have to go to their world. They're not going to come to us. They're not going to learn about the past. They are interested in the future. So in a way, we have to be careful before we pass big sentences and say, oh, this is not allowed, this is allowed. And we have also to involve them in decision making.
Well, the world, I like to say the world is gray, but an awful lot of people see it in black and white. And right now we're seeing social media in black and white as adults. Particularly the ones who are the lawmakers and the principals of the schools and what have you. How do you do this? How do you get from us talking about it, and I think what you say makes absolute sense, to actually some kind of policy? Because you can't have every school going off on its own in a school district. There has to be a policy. And if you say we don't want any phones in the schools during school hours, parents depend in our country, because we have so many school shootings. Parents are terrorized by this. They want their kid to have a phone so that you can call your mom, It's like everything that has a plus has a minus. How do you weigh them against each other? How do you put them together so maybe we're not talking about fairness here, but we're talking about best practices? How do you get to that point?
Okay, funny enough, I always, whenever I got a spare time, I think about this topic on how, if the school want to do a policy or a hospital want to do a policy, and I am against, but as I said, I'm not talking from evidence base here, because if to say something, you have to be backed by research. But personally, I believe, and this is maybe a call for phone companies or whoever they design these phones, we need phones that don't have cameras. We go back to this Nokia, and phones that just a landline for the child to be able to contact his parents. All right, so we don't want much of internet in it to be used, or if we can stop or kind of disable these things while the child is in school. So there is no internet or limited internet, just to use, maybe to send a WhatsApp message to your mom, all right, instead of doing a phone call.
Yeah.
So if the phone companies can do that, to disable some function in the phone during school time, so the child, if in bad need, can make a phone call, all right, that's it. But there is no need for other things. But to take a mobile phone completely off a child, and I'm saying this, I believe the school, when they want to do a policy, or the government, they need to consult school, but the school need to have a representative from mature age group of kids and children. Because if you don't listen to young people, if you don't listen to their views, and these are going to be the leaders of the future, this is going to be the doctors, the teachers, the journalists, the nurses, we have to listen to them, you know. And because if we listen to them and kind of take their views seriously, they will have an effect on the other kids as well. I don't believe in a policy being done without consulting the young people.
I'm with you on that. I've always, we were both young people once.
Yeah.
Mine was a little further back than yours. But I did know something when you come back and you look at your young self. I didn't know everything like I thought I did, but I knew something. And it was worth listening to on some subjects. And I've done some teaching with college age kids, and I love talking with them. And the word is with them, not to them. It's great to get them into a conversation because they lead you in a direction you might not have thought of, and that makes sense when you do think about it. And maybe that's part of the problem. The adult world is so upset about all this, and the kids are upset too, and nobody quite knows how to get to this point where we listen to each other. And you, as a psychiatrist, no matter who who is in your practice, there are certain um, uh, general precepts that that we don't know. You could really help us along that line. How do we talk to each other?
Can I also just add one thing to the previous point, or this point, is that the parents or policymaker, politician, principal, they are from a generation that I don't think they are close enough to this Z or Alpha generation. Because the Alpha generation, or the young people or the children we're seeing nowadays with some of the Z generation, their parents, by the way, are not far from them. But most of the policymaker, politician, in a way, let us admit, we are talking about our own days and safety.
Yeah.
Let us try to live in their life. If we can't do that, I believe this is why we need their views. We need their views. We definitely need to have, so I can't see a policy being made without asking young people, all right? And maybe there will be that the school prefect, a group of children that are trusted within their age group, they can lead that. And if we kind of have a discussion that they kind of listen to some of their views and take it seriously, they will see that as they're winning, and then they will abide. But for us to set a rule and to say, no, this is a decision, this is a rule passed by the Congress or passed by whatsoever authority, I don't think it's a right way of approaching that. And you're right, maybe we need a group of psychologists, group of psychiatrists, pediatricians, school teachers, parents of different age group, grandparents. I believe many people need to be invited, because we have to assess the risk of not having the phone at all, as opposed to the risk of having been exposed to whatever, cyberbullying, sexual exploitation, being isolated, being groomed. But that risk, as I said to you, and we need to invite also mobile companies, because they can help us with their technology. And as I said, disable certain thing at a certain time. I'm not an expert in technology, but I believe nowadays everything could be done.
I'm just thinking of my own Apple iPhone, and what I can do in the settings app of my phone, what I can turn on, what I can turn off, how detailed it is. There could be a protocol that the phone companies could simply make in a software update. It's not even hardware, where it could interact with the school And the school could set up something that every time you walk into the school building, this goes off and this stays on. And I think that is not that difficult, actually. And if you're an Apple or a Samsung or whatever, so I think you have something. I think you need to write a book. I'm serious.
Mm.
Um, let's just move on in the same direction, because we're talking a little bit about the future. I mean, none of this is going to happen tomorrow. In the meantime, we do have our problems with kids as things exist now. Is there any way to make things better while we're getting to the point of making it much better? I mean, is there a way to just get more services to our kids right now?
There is a system around the child, as I said.
There's a
So
system, but what I'm saying is the child, him or herself, or their selves, would the child know enough or think that way, that on a day when they're really truly depressed and they think they have nobody to talk to, would they think to call a suicide hotline or some other entity or number that they've seen somewhere? Or do they just feel so alone that even their best friend can't help them?
actually, the kids here are taught from a very young age in school, if you are in trouble or even you experience problem at home, they can ring. They know
Do
how to
they?
ring. Yeah, yeah. So
Excellent.
every child got a number, and I'm aware of kids even being manipulating or abusing. No, I'm not gonna say abusing. Saying to their parents, if you don't give me that, I will ring that number, because when that number is contacted, things are taken very seriously. So they know how to ring the child line. So the school, because the school worry also about not only the child feeling low, is if the parents is not treating the child nicely, if the child is alone, the child knows how to ring. And this is another reason of using a smartphone, because not many people nowadays got a landline, actually.
No, true. Absolutely. Um, okay. I think, as a kind of a wrap up here, we've been talking about the future. What else would you put into a health system in your area for the future, if you could design it, that would deal with the demographic issues, the I think the Gen Z generation is a very large group of kids. I'm not sure that Alpha is quite so large, but put them together, it's a lot of kids. What do you need so that you can make things better?
I need to listen to them all the time. I need to give them kind of avenues to express their feelings and ideas and thoughts. I need to share them in designing their own future. And I also would like to invest in parents, because some of this behavior, so when a mother would come and say, my child is addicted to the phone and he doesn't leave it at all, or she doesn't, or she stay with it 24/7, you will be amazed. Sometimes I will go to the waiting room, the child and his mother, everyone will be looking at his own device. So parents, parental education, parental responsibility, parents classes, I believe we need to equip parents. And we also need to equip parents to be, because some people will go into this being a parent without knowing much about children. So this is at a child level and at a parent level. A school curriculum, really, like we include sex education, we include a lot of things, religion. Really, this is a hot topic. We need to educate them about mental illness. Mental illness should be part of the curriculum, and how to sail through. So I believe in the school. I believe the school is capable of doing more. And in the past, teacher used to say, we don't have enough time, we just hardly do our lessons. But if it is part of their curriculum, the teacher won't feel it's a burden, because then we can have, like a mental health nurse, we can have a mental health teacher to teach the mental health curriculum. So this is at a wide level. So I look at the child, I look at the parent, and also this part of the curriculum. And then I would rather, like with policymaker, as I said, make sure that there is a young people representative, and even with a policymaker, I make sure that there is a policy, maker there who's not far from Generation Z, because we look at the world differently.
It's also, though, going to take more money. And if the NHS right now is starved for funds in certain areas, education is even more starved, particularly in the big cities. So something, I think you said this when we were talking earlier before the podcast, there's this pot of money and everybody wants to put their fingers in it. And how are you going to get this extra money to do what you're talking about? I mean, if you had a mental health teacher, that's another person that has to be paid in
Yes, but
every school in the district,
This will go from the education budget. It's not going to go from health budget.
Yeah, but yeah, it's got to come from education funding. But then on the health funding level, if there are more young people who have problems, who need to see somebody like you, or at the lower level, no, those people have to be paid too. They have to be educated. I mean, you just look at it and I see money, money, money.
Yeah, we can use the media as well. We can go back to the media to give us all these also, mental health education. Because as I said, since COVID, if there is any benefit of that COVID at all, is that we went, we're using now online kind of appointments. There is an online school. There is a lot of online service. So we can use the media as well to promote good mental health. I'm with you with the money thing. The money will never be enough till the last day in this planet.
Yeah.
But we need to think strategically. I'm not a politician, but all I'm saying, we have to make sure that, because as the WHO said, there is no health without mental health. No one is healthy if you got a mental illness.
Yeah.
So we really need to invest heavily in this population. But we can use, and this could be even going through small steps, but we have to start somewhere. But if we put the budget as an obstacle and we put all our dreams in one pot, we will never move an inch.
All right, one last question. You're talking basically as a member of the NHS in one country, the UK. I'm sitting here in the United States. My sense of teenagers, as I meet them through the school that I had been teaching in, where those students come from all over the world. But when it comes to what we've been talking about, they're all the same. They know the same music. They all want to go to the Taylor Swift concerts. I mean, they're looking at the same websites and they're looking at the same stuff. Not websites, the same social media, and they're looking at the same stuff on TikTok as they all know mostly English, but even if they don't, they're looking at just what their compatriots in another country are looking at. So it's almost like each country is trying to reinvent the wheel. And that when it comes to young people, there almost ought to be some international protocols where you can all get together and compare notes and then try to do things that work internationally. And that might help in that sense and save some money also.
Actually, what you just said, it speaks volume. The social media is uniting these people, and people at each country at the policy level, because they are from a different generation completely. So as you said, trying to reinvent the wheel. So probably the best approach is that we use the social media to talk to these young people.
It's you can. I see all kinds of people doing TikToks, and if you figure out how to reach them, you can reach them. I mean, if you hire a part-time teenager for your media company to make TikToks, saying the right thing, maybe you'll get somewhere.
Or we can use influencers like Taylor Swift. We can use the people that they are very fond of to send global messages.
True. I know with WhatsApp, my WhatsApp is full of people from a bunch of different countries. It has brought us all together in a way that I didn't know years ago. And I kind of like to end with that. I guess maybe one last question about the NHS in general. Do you, and this is back to being very localized, do you think the NHS is going to survive as what you know it now, or is it going to have to be reinvented? Or will it fall apart before they put it back together again? Because it just sounds so dire with what we read.
Okay. Will the NHS survive? I will say it will survive. And the way I personally look at the NHS, you've been to London, you said, yes?
Mm-hmm.
The NHS for me is like the London Red Bus, all right? And the driver of that bus is the National Institute of Care and Clinical Excellence. Nice kind of drive all these people safely. And if that bus sometimes is slow because of traffic, policies, underfunding, sometimes it goes its own speed because the funding is there, because I've been, in the NHS for a number of years, and I've seen the bus slowing, the bus going at its normal speed. But I'm dead sure if that bus stops, the passenger will go behind the bus and push it to go back to its normal track.
Beautiful. Beautiful. I am visualizing as you speak the time that my husband and I took the night bus back to our hotel. And yes, it went everywhere and finally got there. You're absolutely right. Perfect. All right, Amani, thank you so much for coming on the podcast. Really appreciate it.
Thank you very much for inviting me again.
Dr. Amani Hassan is an experienced practicing child and adolescent psychiatrist in Wales, a consultant, as many doctors are called in the NHS. She chairs the Faculty of Child and Adolescent Psychiatry at the Royal College of Psychiatrists in Wales and works also in learning disability psychiatry. There's a more detailed bio in the show notes. As you know, we talked only a little about the doctor shortage in the NHS, the long waiting list to see a doctor, and the work overload as a result. It's not unique in the UK, of course, but the effects of the shortages seem to be taking a much worse toll there than in the rest of Europe or in the US. It's affecting some doctors' mental health. So in the next episode, we'll hear from another doctor. He's a consultant, in NHS terms, who works in England, not far from London. He's a GP, that's a general practitioner, like a primary care doctor in the United States, and he has a lot to say. I schedule one new podcast episode a month, so look for this next episode in June, and the drop day is generally the third Tuesday of the month. Updates on my show notes on the podcast page. I'd really appreciate it if you'd subscribe and, of course, share. We're on Apple, YouTube Music, Spotify, TuneIn, Amazon Music, iHeart, Podchaser, and my host platform, the Podbeam app. The video version is on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. If you like the podcast, please leave a review or a rating wherever it is that you watch or listen to your podcasts. I'm Stephanie Shelton, and until I see you again, please take care of yourself and all those you love. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.